the entire setting for medical education creates the lesson in medical professionalism. What we need to be doing is taking the opportunity to jump on every conflict that comes up in the training and work environment, and take the opportunity to delve into that conflict in greater detail so that young physicians can develop a moral and ethical construct for making professional decisions.
As an educator, I think a lot about how do we teach students to embrace professionalism. We do it in two ways. The time-honored way of having them read the texts that enlighten them about these traditional domains, these principles. And then secondly, having them do case analysis around complicated patient cases that exemplify conflicts of interest, or a clash of values. What's so true in medical ethics is that if one emphasizes one value, it's often at the expense of another. So we have students actively grapple with that. It helps them understand how complicated the good patient care is in the context of very finite resources.
One of the things that I do is I'm responsible for giving an orientation session to all new trainees at Brigham in all specialties where I talk about professionalism. And one of the things that I do is I say that my concept is that they're in the center of, each of them is in the center of a circle of several concentric circles that are going to be around them to support them in their work. When I trained, the only circle I think that we thought of was our year in training. So it was sort of like, I think, being in the armed services apparently, where you were kind of in a boot camp with your fellow trainees and you would bond together to get through the year. And that's an incredibly important community. I think people understand now that there's many concentric communities, and they include obviously the whole program, the faculty, so the whole department, the graduate medical education if it's in training, but for faculty it might include the medical school. You know, we're all here and a part of our mission is to teach. It may include a healthcare delivery system. I mean, these are all communities that actually I think need nurturing so that we can say that we feel part of a system that we're invested in. And I think, you know, the idea of being invested in something outside just that physician-patient relationship is crucial, to be honest, only because it will support the physician-patient relationship.
We're making an effort now to do interprofessional education, bringing clinicians who will have to function on the team together as students and having them work around case analyses as if they were a team in practice, and learning how to respectfully disagree, bring different perspectives to the issue, debate effectively and respectfully, and really bring to the patient's welfare the very best of each of the professions.
I think the most important thing that medical education can do is make absolutely certain that it is continuously working on improving its own system of care in which residents and students are trained, and that it engage residents and students in being active participants in improving that system of care. In that way, these issues we've been talking about really are inculcated or inbred into the physician in the educational process.
I supervise our internal medicine residents in clinic, and the residents are running from their duties on the inpatient medical ward to clinic. And we only give them 5 or 6 patients in an afternoon, so it's not a huge volume. But between the encounter itself, the paperwork that they have to do, or computer work as it were, trying to navigate, you want to make a prescription for a particular medication, you have to check to see which health plan it is and which particular medication is covered versus not covered. There are a lot of inefficiencies that make it very challenging for a physician in training who ostensibly is trying to develop a style of practice that's going to embody the principles of professionalism. It's difficult for them. And so I think as we think about the structure of training, in a sense, it's creating physicians who unlearn some of the natural tendencies they have towards altruism, towards investing in relationship, by putting them in a system which basically says, well, there's not really time or space for this, so you learn ways around it. They learn to be very efficient with time, to limit the amount of time they spend with patients, to focus on just sort of check boxes, making sure this is done, that's done, that's. And most of the things are appropriate things to do, but there's a major shift towards the biomedical, pushing out some of the relational kinds of things that I think patients are really looking for and that would be more rewarding to them as physicians.
In my day-to-day work as the Dean for Medical Education, I deal with medical students who we're teaching the very fundamentals of medical professionalism, and very often that gets translated into behaviors of medical professionalism. And one of the things that I've learned from my students is that if we stay anchored in the behaviors of the professional, the student can miss the bigger picture. They can miss the tenets of professionalism, they can miss the social contract with society. And the way I'm currently working to reframe it with our students, residents, and faculty is to ask them to do appreciative inquiry related to when was the last time you saw someone behaving professionally? Or tell me about the most professional thing you did during your month on our general medicine service. And in that context, I hear the compassion, the empathy, I hear those virtues of altruism and integrity. And so I'm trying to shift the conversation to the conversation of, let's think about where in our environment do we see examples of the ultimate consummate professional, and then try to encourage modeling of those examples.
When we say medical school isn't just about accumulating knowledge, it begins to give us space to emphasize those other skills that are equally important. How do you communicate with the patient, especially when you have to deliver bad news? How do you communicate with a patient when they're angry, when they're so frightened they can barely listen to you? We begin to emphasize things like the social context for patients. In my last deanship, we would send medical students not to the clinic to meet their first patient, but we would send them to the patient's home, where they'd really see what the burden of illness was for that patient and their family in their day-to-day life.
If you wanted to have internal medicine residents learn how to truly develop a relationship with a group of patients, a panel of patients, you might, instead of having them see random patients that happen to come in when they come to clinic, you might say, let's give you a group of patients from the first day of your residency. You're going to work with these patients for 3 years, however many years, and give them a profile on those patients, give them some background information so they can begin to learn those patients. That would be a completely different way of organizing medical education, a completely different revolution built around the principles, rather than having a system where we're trying to cram the principles back in to a system that fundamentally is a little out of sync with those. Models like that are taking hold, and in some areas I'm aware of a program at UC Davis where the residents actually are given a panel of patients. So what that means is that resident is going to have a representative experience of what primary care practice might be like, and is therefore going to have a more realistic experience.
I think what we're obligated to do now, we have students who are prepared, we have educators who I think are really giving them some better tools to develop their medical professionalism. I think it's incumbent on us to remove some of the obstacles in the healthcare system now that actually keep them from living up to their full potential.